is commonly seen in children and young adults. Overcrowding and poor sanitation facilitate the spread of this virus. The spread of infection is mainly by the fecal-oral route and arises from the ingestion of contaminated food or water. There is no carrier state. Disease is usually self-limiting. However, 10 to 15% of patients might experience a relapse of symptoms during the 6 months after acute illness. Acute liver failure from hepatitis A is rare. Overall case fatality is 0.5%. The risk for symptomatic infection is directly related to age, with more than 80% of adults having symptoms compatible with acute viral hepatitis, and the majority of children having either asymptomatic or unrecognized infection. Antibody produced in response to hepatitis A virus infection persists for life and confers protection against reinfection. Now, how is hepatitis A virus transmitted? Person-to-person transmission through fecal-oral route, that is, ingestion of something that has been contaminated with the feces of an infected person. Most infections result from close personal contact with an infected household member or sex partner. Common source outbreaks and sporadic cases also can occur from exposure to fecally contaminated food or water. Uncooked hepatitis A virus contaminated foods have been recognized as a source of outbreaks. Cooked foods also can transmit hepatitis A virus if the temperature during food preparation is inadequate to kill the virus, or if food is contaminated after cooking, as occurs in outbreaks associated with infected food handlers. Waterborne outbreaks are infrequent in developed countries with well-maintained sanitation and water supplies. Who is at increased risk for acquiring hepatitis A virus infection? Travelers to countries with high or intermediate endemicity of hepatitis A virus infection. Second, users of injection and non-injection illegal drugs. Third, persons with clotting factor disorders. And fourth, persons working with non-human primates susceptible to hepatitis A virus infection. Now, the sign and symptoms. How can we find out that whether this child is having acute viral hepatitis? Some persons, particularly young children, are asymptomatic. When symptoms are present, they usually occur abruptly and can include the following: fever, fatigue, loss of appetite, nausea, vomiting, abdominal pain, dark urine, clay-colored bowel movements, joint pain, and jaundice. Now the question is, when symptoms occur, how long do they usually last? Symptoms usually last less than 2 months, although 10 to 15% of symptomatic persons have prolonged or relapsing disease for up to 6 months. Now, the investigations. First of all, the liver biochemistry. A raised serum AST or ALT, which can sometimes be very high, precedes the jaundice. In the icteric stage, the serum bilirubin reflects the level of jaundice. Serum AST reaches a maximum of 1 to 2 days after the appearance of the jaundice and may rise above 500 international units per liter. The aminotransferases may remain elevated for some weeks and occasionally for up to 6 months. Hematological tests, there is in leukopenia with a relative lymphocytosis. The erythrocyte sedimentation rate is raised. Regarding the viral markers, antibodies to hepatitis A virus, IgG antibodies, are common in the general population over the age of 50 years. But an anti-HAV IgM means an acute infection. In areas of high prevalence, most children have antibodies by the age of 3 years following asymptomatic infection. Now the question is, how long does hepatitis A virus survive outside the body? How can the virus be killed? Hepatitis A virus can live outside the body for months, depending on the environmental conditions. The virus is killed by heating to 185 degree Fahrenheit or 85 degrees Celsius for 1 minute. However, the virus can still be spread from cooked food if it is contaminated after cooking. Adequate chlorination of water for 5 degrees C for 1 minute is adequate to kill the virus. Now, the course and prognosis. The prognosis is excellent, with most patients making a complete recovery. The mortality in young adults is 0.1%, but it increases with age. Death is due to fulminant hepatic necrosis. Hepatitis A virus hepatitis never progresses to chronic liver disease. That is the good thing about this virus. Now, the treatment. There is no specific treatment. Usually, supportive measures are helpful. For example, if the patient is complaining of fever, you may prescribe that child mefenamic acid, that is Ponston syrup, or if the patient is vomiting, you may prescribe an antiemetic for symptomatic relief, or if the appetite of the child is decreased, you may prescribe syrup Vidalin L, which is containing lysine in it and multivitamins that will help in improving the appetite of the baby or the child. If the child is feeling weakness, you can offer a glass of water and add 3 teaspoonful of glucose in it, and you give that to that child 3 times a day. It will help in improving the glucose level in the blood. So all measures are supportive measures. There is no specific treatment, and usually the children recovers out of it. Previously, there is used to be very high incidence of not allowing the child taking fatty foods. But nowadays, the recommendation is that if the child wants to take some amount of fat in the diet, he can take that diet as well. Now, can hepatitis A become chronic? Answer is no. Hepatitis A does not become chronic. Another question that is asked is, can persons become reinfected with hepatitis A virus after recovering from hepatitis A? Answer is again no. Immunoglobulin G antibodies to hepatitis A virus, which appear early in the course of infection, provide lifelong protection against the disease. Now, how is HAV infection prevented? Good hygiene, including hand washing or use of hand sanitizer after using the bathroom, changing diapers, and before preparing or eating food is also integral to hepatitis A prevention. So how can you prevent? By hand washing, use of hand sanitizers, especially after using the bathroom and changing diapers, and before preparing or eating food. How is hepatitis A virus infection prevented? Vaccination. With the full 2-dose series of hepatitis A vaccine is the best way to prevent hepatitis A virus infection. Immune globulin is available for short-term protection approximately 3 months. Protection is provided by the immunoglobulin against hepatitis A. Both pre and post exposure, you can give it. Immunoglobulin must be administered within 2 weeks after exposure for maximum protection. Now, the second virus that is seen causing acute hepatitis is hepatitis E virus. Hepatitis E virus is an RNA virus which causes a hepatitis clinically very similar to hepatitis A. It is enterally transmitted, usually by contaminated water. There is no carrier state and it does not progress to chronic liver disease. Epidemics have been seen in many developing countries. It has a mortality from fulminant hepatic failure of 1 to 2%, which rises to 20% in pregnant women. And ELISA for immunoglobulin G and immunoglobulin M and THEV is available for diagnosis. Hepatitis E virus RNA can be detected in the serum or stool by PCR, that is polymerase chain reaction. Prevention and control depend on good sanitation and hygiene. Now, after discussing hepatitis A and E, now we are going to discuss about fulminant hepatic failure. Fulminant hepatic failure, acute liver failure, is clinical syndrome resulting from massive necrosis of hepatocytes or from severe functional impairment of hepatocytes. Fulminant considered less than 8 weeks from the jaundice to encephalopathy. Jaundice, encephalopathy, stupor, coma, decreased synthetic function with INR of more than 1.5 and new ascites. So if you see a child who is brought to you with the history of jaundice of less than 8-week duration and is brought to you in a stupor or a comatose position, and when you do the prothrombin time is increased and international normalized ratio is more than 1.5. And if you do the ultrasound, you find ascites that will confirm that most likely this patient is suffering from hepatic encephalopathy. Now the etiology. Fulminant hepatic failure can be a complication of viral hepatitis A, B, D, and E, and can also be caused by autoimmune hepatitis in about 5% of cases. An idiopathic form of fulminant hepatic failure accounts for 40 to 50% of cases in children, in which the cause is not known. If you go into the etiology of it, you can have vascular causes like Budd-Chiari, hepatic vein thrombosis, ischemia, shock liver, hepatic veno-occlusive disease, portal vein thrombosis, arterial thrombosis, similarly trauma causing laceration to the liver, or neoplastic, either primary or secondary lesions in the liver. Beside this, inherited congenital disorders like Wilson's disease, which is because of excessive deposition of copper in the different viscera, hemochromatosis, in which the iron is deposited in excessive amounts in different viscera, alpha-1 antitrypsin deficiency, galactosemia, tyrosinemia, urea cycle disorders, ornithine transcarbamylase deficiency, fructose intolerance are all the list of inherited and congenital metabolic disorder that can lead to hepatic encephalopathy. Regarding the drugs and toxins, acetaminophen, that is the paracetamol, that is hepatotoxic. Alcohol, chronic use depletes glutathione stores, and that may lead to a person to develop fulminant hepatic failure. Antidepressants, if the patient is taking amitriptyline or nortriptyline, he is at risk. And oral hypoglycemic agents. Now the pathology. Panlobular necrosis, common in medication-related and virally mediated disease. And centrilobular necrosis extending along the portal tracts is common in acetaminophen toxicity. Microvesicular steatosis suggests valproate or salicylate as primary injury or acute fatty liver of pregnancy. Now, the laboratory studies that you will do in a patient suspected case of hepatic encephalopathy. First of all, you will check the sugar. Usually, these children have hypoglycemia, and you give 4 cc per kg of 10% dextrose water IV to treat that hypoglycemia. You check the serum ammonia level, that is usually raised in patients with hepatic failure. And if you do the chemistry, you will find electrolyte imbalance. And if you do the liver function test, that will show the raised AST, raised serum bilirubin, raised alkaline phosphatase. And if you check the serum albumin level, that will be low. Serum lipase may be increased. And if you do the prothrombin time, that will be increased. And INR, that is international normalized ratio, is more than 1.5. So if you see a child with a history of jaundice within the last, say, 8 weeks, and he is brought to you with the complaints of altered state of consciousness, and you should investigate the child as a possible case of hepatic encephalopathy, and you do the RBS, serum ammonia, urea creatinine electrolytes, liver function test, lipase, and prothrombin time, and that will help you to reach the diagnosis. Beside this, you will also do the blood CBC, complete blood count. You can do the serum lactate, that will be raised. And to find out the cause of hepatic encephalopathy, acetaminophen, and salicylate level can be done. You can do the toxicology screen. And beside this, viral serologies are done, like anti-HAV IgM. If that is raised, it will tell you that this patient is having fulminant hepatic failure secondary to hepatitis A virus. If the hepatitis B virus surface antigen and hepatitis B core antibody IgM is present, then you will suspect that this patient is having acute fulminant hepatitis secondary to hepatitis B virus. And if you see the anti-HEV IgM, that is antibodies against hepatitis E virus IgM increase, that will indicate that this patient is having this fulminant hepatic failure secondary to hepatitis E virus. Beside this, you will be also doing, if you are suspecting autoimmune hepatitis as underlying reason for acute fulminant hepatitis, then you will be doing the anti-nuclear antibodies, ANA, anti-smooth muscle antibodies, ASMA, liver, kidney, mitochondrial antibodies, LKMA, and you do the immunoglobulin levels. If you are suspecting Wilson's disease as a cause of fulminant hepatic failure, you will go for serum ceruloplasmin level, that will be low. Serum free copper level, that will be raised. And if you are suspecting AIDS as a cause of hepatic encephalopathy, you will do for HIV test. And if you are suspecting sepsis, then you will go for blood cultures. Now the radiology. Liver ultrasound with Doppler's evaluation, clot, and you do the liver ultrasound with Dopplers to evaluate for any clot, any parenchymal damage. You do the CT brain for looking for cerebral edema and any mass lesion. You will do the CT scan of the liver and or MRI to delineate anatomy and it will help in transplantation as well. EEG is done in the obtunded patient to rule out any seizures, and liver biopsy. Now the complications. Coagulopathy, the patient can start bleeding from different sites. Encephalopathy, patient will be having altered state of consciousness, and there could be cerebral edema and herniation of the brain. There could be hypoglycemia that can cause fits. There could be renal failure and systemic inflammatory response syndrome, SIRS, can be there. There could be slow venous return. There could be sepsis. Fulminant hepatic failure is incredibly deadly, so triage and treat aggressively. A specific treatment for cause of fulminant hepatic failure should be identified and treated accordingly. So that now we are going to discuss. ये हटाना है यहाँ से, ये स्क्रीन पे तस्वीर खुद चला, मगर मेरे को पढ़ने में मुश्किल हो रही है ना, पढ़ा नहीं जा रहा. हाँ, okay, thank you. Now the management. If the patient is having bleeding, you have to correct the coagulopathy. So correction of coagulopathy not indicated unless active bleeding is present or you are going to perform a procedure on the patient. And for that purpose, if the patient is bleeding or you are planning a procedure, you give FFP, fresh frozen plasma, 15 ml per kg or 4 units of FFP are transfused. Second option is you can give cryoprecipitate to correct the coagulopathy. Third option is you can give factor 7A for unresponsive bleeding. The dose is 4 microgram per kilogram push. And platelet transfusion only is done when the platelet are less than 10,000. Or if you are planning a procedure, then the platelet count, if it is less than 50,000, you do the platelet transfusion. So general guidelines for management of coagulopathy is that generally you don't give FFP or platelets. You give FFP or platelets only when the patient is bleeding or you are going to plan a procedure on the patient. If that is the situation, then the options are you can give FFP 15 ml per kg or 4 units of FFP, or you can give cryoprecipitate, you can give factor 7A for unresponsive bleeding, 4 microgram per kilogram push. And if the platelet count is less than 10,000, you transfuse platelet transfusion 10 cc per kg, or if you are planning a procedure, then the platelet count must be at least more than 50,000. So if it is less than 50,000, you give platelet transfusion and then do the procedure over the patient. The another problem with the hepatic encephalopathy is the cerebral edema. Lactulose via nasogastric to decrease ammonia. Lactulose is given through the nasogastric tube. Second, mechanical ventilation to protect airway and hyperventilate for a short duration of time. Third is head of bed elevated to 30 degrees. Fourth, mannitol 0.5 to 1 gram per kilogram The goal is to maintain the osmolarity around 320 osmol. Hypertonic saline, 3% sodium chloride given. The goal is to maintain the sodium between 145 to 155 milliequivalent per liter. And the patient is having fits, barbiturate, coma can be given. Hypothermia is under investigation, that if people feel that if you do the hypothermia, that will help in reducing the cerebral edema. Seizure control is done with phenytoin, which is an anti-epileptic drug, and a call is given to neurology or neurosurgery early in this situation. The third problem with fulminant hepatic failure is the renal failure. 1/3 of patients will develop oliguric acute renal failure. In this, you have to do the fluid resuscitation, chronic venous hemodialysis as indicated, avoid nephrotoxic medications, avoid non-steroidal anti-inflammatory drugs. Now the management of cardiovascular and endocrine issues. Fluid resuscitation is done. Dopamine or norepinephrine is given SOS. Impaired gluconeogenesis is there. So you maintain the sugar level. For that, you do the capillary blood glucose level every 12 hours. And if the patient is having hypoglycemia, you can start the child on 5% or 10% dextrose containing solution as necessary. And you monitor the potassium, phosphate, and magnesium level. Now, another thing that is used in the management of acute fulminant hepatic failure is antibiotics. Empiric antibiotics for progressive encephalopathy is given, or when the signs of SIRS, systemic inflammatory response syndrome, temperature more than 38 degrees centigrade or less than 36 degrees centigrade, white blood cell count of more than 12,000 per millimeter cube or less than 4,000 per millimeter cube, or pulse rate more than 90 beats per minute. So these are the signs of SIRS. SIRS is systemic inflammatory response syndrome. And how you diagnose SIRS? If the temperature is more than 38 or less than 36 degrees centigrade, if the white blood cell count is more than 12,000 or less than 4,000 per millimeter cube, and if you see the pulse rate more than 90 beats per minute. So in a patient with progressive encephalopathy, in a patient who is showing you the signs of SIRS, in a patient with persistent hypotension, there is a role of empiric antibiotics. Zosine and fluconazole considered initially. In hospital-acquired IV catheter infections, consider vancomycin. Now the management. Transplant. Prior to orthotopic transplant, mortality was more than 80%. So when the liver transplant was not on, majority of patients used to die because of fulminant hepatic failure. Now, once the orthotopic liver transplant is available, the mortality has decreased to around 6%. So 6% of orthotopic liver transplant due to fulminant hepatic failure. Mortality now is around 20 to 40%, and it is center dependent. Depending upon the expertise of the center, the mortality vary. But it is much less as compared to the situation when there was no liver transplant being done. So that was about the hepatic encephalopathy. ये एक लेक्चर खत्म हो गया, एक और लेक्चर है जो मुझे डेस्कटॉप से फिर वो शुरू करना है, इसको बंद करके वो शुरू करना है. आप ये शुरू करें, हाँ इसको खोलें. Now we are going to discuss the another topic, which is cirrhosis, chronic liver disease. Definition: chronic liver disease is a process of the liver that involves a process of progressive destruction and regeneration of the liver parenchyma, leading to fibrosis and cirrhosis. So chronic liver disease is a process of the liver that involves a process of progressive destruction and regeneration of the liver parenchyma, leading to fibrosis and cirrhosis. So there is continuous damage is being done to the liver parenchyma, and the liver is trying to compensate for it by regeneration, and this process is going on and ultimately leading to fibrosis and cirrhosis. Now the etiology. Major congenital disorders leading to chronic disease include biliary atresia, tyrosinemia, untreated galactosemia, and alpha-1 antitrypsin deficiency. These are the major congenital disorders that lead to chronic disease. What are those? Biliary atresia, tyrosinemia, untreated galactosemia, and alpha antitrypsin deficiency. In older children, hepatitis B virus, hepatitis C virus, autoimmune hepatitis, Wilson's disease, primary sclerosing cholangitis, cystic fibrosis, and biliary obstruction secondary to choledochal cyst are leading causes. So if you look into the causes, in the earlier stage, in infancy, biliary atresia, tyrosinemia, untreated galactosemia, alpha-1 antitrypsin deficiency are more common. And in older children, hepatitis B, hepatitis C, autoimmune hepatitis, Wilson's disease, primary sclerosing cholangitis, cystic fibrosis, and biliary obstruction secondary to choledochal cyst are leading causes. Now let us discuss briefly about biliary atresia. It is a congenital or acquired disease of the liver. Infants and children with biliary atresia have progressive cholestasis with all the usual concomitant features that are associated with cholestasis. That is, the patient will be presenting to you with jaundice. He will be complaining of pruritus. There would be malabsorption with growth retardation. Fat-soluble vitamin deficiencies will be there because the bile salts are not reaching to the small intestine because of the obstruction in the biliary tree that lead to fat-soluble vitamin deficiencies, hyperlipidemia, and eventually cirrhosis with portal hypertension. So these are the manifestations of biliary atresia. Second reason is for chronic liver disease is tyrosinemia. It is an error of metabolism, usually inborn, in which the body cannot effectively break down the amino acid tyrosine. Symptoms include liver and kidney disturbances and mental retardation. Untreated tyrosinemia can be fatal. Most inborn forms of tyrosinemia produce hypertyrosinemia. So if you do the serum level of tyrosine, that will be elevated. Now the galactosemia. It is a rare genetic metabolic disorder that affects an individual's ability to metabolize the sugar galactose properly. Galactosemia follows an autosomal recessive mode of inheritance that confers a deficiency in an enzyme responsible for adequate galactose degradation. So for adequate galactose degradation, there is an enzyme, galactase, that should be there. If there is deficiency of this enzyme, then the galactose will be found in increased amount in the blood, and that will cause damage to the different organs. So galactosemia follows an autosomal recessive mode of inheritance that confers a deficiency in an enzyme responsible for adequate galactose degradation. The disease usually appears in the first few days of life following the ingestion of breast milk or formula milk. Baby presents to you with vomiting, liver enlargement, and jaundice. And these are often the earliest signs of the disease. So if you see a newborn baby who presents to you with the history of vomiting, liver enlargement, and jaundice, and there is a history that the baby was all right in the first few days, and then when the baby was started on breast milk or formula milk, the baby, after starting of the milk, developed jaundice. If unrecognized in the newborn period, the disease may produce liver, brain, eye, and kidney damage. Another metabolic reason could be alpha 1 antitrypsin deficiency. It is a genetic disorder that causes defective production of alpha 1 antitrypsin, leading to decreased alpha 1 antitrypsin activity in the blood and lungs, and deposition of excessive abnormal alpha 1 antitrypsin protein in the liver cells. There are several forms and degrees of deficiency, principally depending on whether the sufferer has one or two copies of the affected gene, because it is a codominant trait. Several alpha 1 antitrypsin deficiency causes, severe alpha 1 antitrypsin deficiency causes pan-acinar emphysema or chronic obstructive pulmonary disease in adult life in many people with the condition, as well as various liver diseases in a minority of children and adults, and occasionally more unusual problems. Now, something about the pediatric hepatitis B that can also lead to chronic liver disease. The hepatitis B virus discovered in 1966 infects more than 350 million people worldwide. Hepatitis B virus can cause acute and chronic liver disease. The clinical presentation ranges from subclinical hepatitis to symptomatic hepatitis, and in rare instances, fulminant hepatitis. Long-term complications of hepatitis B include cirrhosis and hepatocellular carcinoma. Perinatal or childhood infection is associated with few or no symptoms, but has a high risk of becoming chronic. So if someone develops the hepatitis B in the neonatal stage, then there is a high likelihood, if not treated properly, that this child will go to develop in the future chronic liver disease. The younger the age, more are the chances of developing chronic liver disease in the future. So perinatal or childhood infection is associated with few or no symptoms, but has a high risk of becoming chronic. A limited number of medications can be used to effectively treat chronic hepatitis B. A safe and effective vaccine is available to prevent hepatitis B infection caused by hepatitis B virus. And in this regard, I would also like to tell that if you see a baby delivered to a mother who has hepatitis B positive, then it is recommended that that newborn should receive 0.5 ml of hepatitis B immune globulin on the one side of the thigh, and he should receive the first dose of hepatitis B vaccine on the another leg, so that that baby can be prevented from developing hepatitis B in the neonatal age. So treatment for a baby who is born to a mother who is hepatitis B positive is you give hepatitis B immune globulin and hepatitis B vaccine at birth, and then you repeat the vaccine according to the schedule. This is how you can prevent a neonate from developing hepatitis B and to develop chronic liver disease in the future. So it is mandatory that every woman who is delivering a baby should get her hepatitis B virus status checked, and if she is hepatitis B positive, then the newborn baby must be receiving hepatitis B immunoglobulin and hepatitis B vaccine as soon as possible after the birth. Now, the pediatric hepatitis C. Hepatitis C infection is a chronic viral infection of the liver that affects 1 to 2% of adults. Fortunately, in children and adolescents, hepatitis C is less common, but it remains a significant health issue. Most children are infected with hepatitis C virus at birth. This is called vertical transmission of infection from mother to child. If a mother has hepatitis C virus, her child has a 1 in 20 chance of becoming infected at birth. The higher the viral load in the mother, the higher the risk of infection. Unfortunately, there is no vaccine available for hepatitis C virus. If you do the immunoglobulin IgG level of a newborn who is delivered to a mother who is suffering from hepatitis C virus, you will find a raised IgG level in the baby that is transferred from the mother to the baby. So if you see IgG level increase, doesn't mean that this baby has developed hepatitis C virus from the mother. What you have to do, you have to repeat it this, say after 3 months, 6 months, sometimes it persists for even 1 year. But if say after 1 year it's still coming positive, it means that this patient might have actually acquired the hepatitis C from the mother. But in the early stages, if you see IgG raised, that is actually reflecting the mother's IgG level status. And it is not telling you that this patient has developed hepatitis C from the mother. To date, interventions at birth such as cesarean section delivery have not been shown to alter the risk of infection at birth. So if the mother is suffering from hepatitis C, there is a chance 1 in 20 of a baby to develop hepatitis C. Another question that is asked usually is that supposing the mother is hepatitis C positive, can she breastfeed the baby? The answer is yes, because the transfer of virus from the milk is very rare. Now, another metabolic or storage disorder that can cause chronic liver disease is Wilson's disease. It is an autosomal recessive genetic disorder in which copper accumulates in tissues. This manifests as neurological or psychiatric symptoms and liver disease. It is treated with medication that reduces copper absorption or removes the excess copper from the body, but occasionally a liver transplant is required. The condition is due to mutations in the Wilson's disease protein ATP7B gene. A single abnormal copy of the gene is present in 1 in 100 people who do not develop any symptoms. They are carriers. Another reason of chronic liver disease is primary sclerosing cholangitis. Primary sclerosing cholangitis is a disease of the bile ducts that causes inflammation and subsequent obstruction of bile ducts both inside and outside of the liver. The inflammation impedes the flow of bile to the gut, which can ultimately lead to cirrhosis of liver, liver failure, and liver cancer. The underlying cause of the inflammation is believed to be autoimmunity, and more than 80% of those with primary sclerosing cholangitis have ulcerative colitis. The definitive treatment is a liver transplant. Another reason of chronic liver disease could be cystic fibrosis. It is an autosomal recessive genetic disorder that affects mostly the lungs, but also the pancreas, liver, and intestine. Difficulty breathing is the most serious symptom and results from frequent lung infections. Other symptoms, including sinus infections, poor growth, and infertility, affect other parts of the body. The average life expectancy is 37 to 40 years in the United States. Another reason for chronic liver disease could be choledochal cysts. They are congenital conditions involving cystic dilatation of bile ducts. They are uncommon in Western countries, but not as rare in East Asian nations like Japan and China. Most of them present in first year of life. Adult presentation is rare and usually at this stage is associated with complication. Classic triad of intermittent abdominal pain, jaundice, and a right upper quadrant abdominal mass is found only in minority of patients. Now, in this slide, what you can see is that first chronic injury like viral infection, hepatitis B, C, alcohol, non-alcoholic steatotic, autoimmune disorders, cholestatic disorders, metabolic disease.
सर आपकी स्लाइड नहीं आ रही है.
अच्छा जी, मैं फिर स्लाइड नहीं आ रही तो मैं आगे चलता हूँ. क्लिनिकल प्रेजेंटेशन ये आ रही है?
नहीं सर.
हेलो, क्लिनिकल प्रेजेंटेशन
नहीं सर, कुछ नहीं आ रहा, बस आपका नाम आ रहा है सर. स्क्रीन शेयर करें सर, शेयर स्क्रीन करें.
ये हमारे कोई है यार, ये इसको स्क्रीन शेयर कर, स्क्रीन शेयर. स्क्रीन शेयर करो. जी, वो आईटी वालों को बुलाया, वो स्क्रीन शेयर करो.
जी सर.
यार स्क्रीन शेयर करना है, वो कह रहे हैं स्लाइड नहीं आ रही. ये हटा दो, हटिए ब्लैक.
स्क्रीन कर दिया.
आई स्क्रीन आई
सर. ये अभी कौन है आपके साथ? तारिक है.
ये बात करें.
तारिक,
अस्सलामुअलैकुम.
तारिक ना.
जी।